the topic is surgery for foramen magnum lesions. Dr. Atul Goel will tell his experience and will show you his slides. Atul, you must unmute yourself. You must unmute. Okay, thank you.
Now it's okay?
Yeah, now it's okay.
Okay, so I will like to take you to the journey of foramen magnum tumors. There are several tumors in the region of foramen magnum, and the surgical strategy indeed will vary. Surgical exposure will vary. Surgical technique will vary. So it is very crucial and very important to know what we are dealing and what is the nature of the tumor is very, very essential. And I must tell you that 30 years ago or 35 years ago, before the era of MRI and before the era of CT scan, this diagnosis, this differential diagnosis was not possible. So there are various lesions in the region of foramen magnum. Meningiomas is one issue which is often discussed. C2 neurinomas is a very common tumor in the region of foramen magnum. Endodermal cyst, I will like to show you. I will like to show you my favorite subject, retroodontoid pseudotumor and some other lesions. And also I will like to show you maybe some chordomas and lower cranial nerve neurinomas and things like that. So this is a copy of Dr. Sukhdeep's dissection, this beautiful brain in the region of foramen magnum. You can see the arch of atlas. You can see the region of tonsils. You can see the vertebral artery in its glory, occipito-atlantal joint, and condyles in the lateral perspective of foramen magnum. So when you approach foramen magnum for reaching tumors, vertebral artery haunts you and hounds you. And it has to be very meticulously and appropriately handled. You see, the course of vertebral artery is very unique. We have discussed on several occasions that it is a dynamic. You move your neck, the vertebral artery moves. You move your neck on the other side, vertebral artery moves on this side and occupies this vertebral artery groove here. So it lands straight like that, and then it turns towards the vertebral artery groove in the C2 facet, and then it turns back into the transverse foramen of C2 to go up into the transverse foramen of C. So you see this loop of facet is very crucial to understand, and then how it comes out into the C2 foramen. And this is the tricky zone of the vertebral artery. Then there are several muscles that we have seen and several triangles to isolate the vertebral artery, to go to the transverse process of C1 arch, which is there, C2 spinous process. Muscles in front of the vertebra are very thin, muscles behind the vertebra are very strong. Basically, these are strong because the entire activity of the craniovertebral junction is from behind. All the muscles are active from behind. Actually, flexion movement is a passive movement. Extension is the active movement. So you extend your neck, flexion comes automatically. So that is why there is, and also our human standing position makes the presence of muscles at the back very important. And this posteriorly located muscles along the entire spine. There's nothing much located anteriorly. It is the basis of human standing position. So we have to learn and understand the various biomechanics of the muscles, of the joints, of the ligaments, and then plan our surgical approach. To come from front is very easy because there is nothing much, no muscles here, but then there is mouth here, and there is a possibility of infection. Retropharyngeal approach is another beautiful approach. How to avoid the mouth and how to include the mouth, whether to come with the use of endoscope from the nose to this foramen magnum region, whether to come from the oral cavity, whether to come from neck, whether to come from lateral. So there are various issues. And I must tell you that the growth of skull-base surgery has been, foramen magnum surgery has played a very important role in the growth of craniovertebral and skull-base surgery. So this is the dissection from the mouth we had done long time ago. And you can see just one incision, you are landing directly on the bones. And transoral surgery and transoral decompression was a very commonly performed operation during our times 30 years ago. Many young people in the audience may not have even, may not even know or may not have ever seen transoral surgery for decompression of odontoid process and decompression of the foramen magnum from the front. But this is one avenue which is important to learn the under region. Cranial nerves are very crucial. Lower cranial nerve, one damage, one cranial nerve, and you are landed with hoarseness of voice. You are landed with difficulty in speaking, difficulty in swallowing. You can actually kill the person by damaging these cranial nerves. So these are most important, in my estimation, most crucial cranial nerves of the body. For survival, you damage lower cranial nerves, you may not be able to survive. Then there are huge condyles. You see the condyles and the facet of atlas are the strongest bones of the body. They are the, if you hold the C1 facet, this is the strongest bone of the body, and occipital condyle. There is no other bone as strong as these bones. And then you see quite a bit of circle of foramen magnum is occupied by the condyle. So transcondylar approaches have been very popular to reach the anterior part of the foramen magnum. So the skull-base surgery has actually developed revolving around anterior foramen magnum meningiomas, but there can be posterior foramen magnum meningiomas, lateral meningiomas, anterolateral meningiomas, anterior meningiomas, superior foramen magnum meningiomas, inferior foramen magnum meningiomas. So there are various kinds of meningiomas, and you have to design your approach depending on how the tumor is. So this extreme lateral approach where I was associated initially was designed by Laligam Shekhar and Chandranath Sen in 1988, and I was involved in the early part of these dissections. And this requires exposure, displacement, and mobilization of the vertebral artery, and a lot of condyle has to be removed. However, in my own journey now of more than 32, 33 years in the surgery of foramen magnum in particular and skull base in general, my exposures have remarkably reduced. So this was my book in 1996, where very radical exposures to skull base have been discussed. Petroclival region has been discussed. Foramen magnum, how to mobilize the vertebral artery, how to resect the condyle, how to do fixation, and how to approach petroclival area by mobilizing the carotid artery, mobilizing the facial nerve, mobilizing the cavernous sinus. So these were the exposures to the petroclival region, clival region, and foramen magnum region. But of course, I have graduated much ahead from those times. So this was one of the exposures which I had described in my book, Supracondylar Infrajugular Keyhole Approach. Like you see here, this is the lateral keyhole approach, supracondylar and infrajugular bulb exposure to the anterior foramen magnum region. Now what I plan to show you in my presentation is discussion on various types of lesions that are present in the region of foramen magnum and how you design your surgical strategy on the basis of the lesions. Even transoral approach was described by Alan Crockard and Chandranath Sen in the year 1991 for foramen magnum tumors. So I had written a smallish note on, I had said that transoral surgery for removal of intradural tumors is not a good option. But now, as we know that transnasal approach, endoscopic approaches are becoming popular. I'm not saying that I like those approaches, and I'm not saying that I will be in favor of those approaches, but those are becoming indeed popular. And I had described surgery for anterior foramen magnum meningioma using a conventional suboccipital approach. I will discuss about this approach very soon. So this is one very common tumor in the region of foramen magnum, and this is C2 neurinoma. You see this C2 neurinoma. Now, of course, with the MRI, we can see the C2 neurinoma and we can diagnose C2 neurinoma very easily. But in my earlier days, with the help of only CT scan, and even before, without the CT scan, these tumors were very difficult to diagnose. Now, even in those days, if you see the literature, even for such tumors, extreme lateral and far lateral approaches have been described in the literature for C2 neurinomas. But you see, this was my understanding of C2 neurinoma in the year 2008. We said that C2 neurinoma is a unique tumor. It is within the dural confines, and we divided into 3 parts, A part, B part, and C part. And in the year 2008, I had said that this is the part, only this part is intradural, other parts are interdural, within the dura. And depending on the basis of these 2 locations, intradural and interdural, we had designed an approach where we did not even do any bone work. So there was no bone dissection, and we removed this. I will discuss about it. So this part was considered as intradural, and this part was considered as interdural. So this is C2 ganglion in the region of lower foramen magnum, and this is the C2 ganglion, and we had related C2 ganglion to Gasserian ganglion, and the Gasserian ganglion is located close to carotid artery. C2 ganglion is located close to vertebral artery. Gasserian is located close to cavernous sinus. C2 is located very close to very heavy venous plexuses in this region. So the anatomy of the tumor C2 neurinoma is similar to trigeminal neurinomas in various respects. I have discussed very elaborately on this subject, and I will just like to a little bit give you a glimpse of my understanding. Like I had said that C2 neurinoma is intradural here. Similarly, I had said trigeminal neurinoma is intradural here. And the trigeminal nerve tumor is interdural here. Like C2 neurinoma is interdural here. So this was my understanding, but I changed my understanding to say that even this part is interdural of C2 neurinoma, and this part of trigeminal neurinoma is interdural here. So this was my evolution. So in this article of mine, which was published subsequently on additional 50 cases, I had said all 3 parts are interdural, and you have to work within the dura to remove, and there is no need for any bone work, no extreme lateral, no far lateral, and not even lateral. You can do midline exposure, and you can do a very beautiful exposure for these tumors. Like trigeminal neurinoma is interdural here, and also interdural in majority of cases here. So this was my understanding, and we have evolved in this, and dural understanding, this extradural approach to cavernous sinus lesion. We know how understanding of dura has helped us. And this was the first article in the literature where extradural approach to tumors involving cavernous sinus were discussed. Of course, Vinko Dolan's work for aneurysms and for trigeminal schwannomas cannot be undermined. Beautiful work, but this was the first paper on extradural approach for tumors within the cavernous sinus was described. And we had very elaborately used interdural approach for dealing with trigeminal neurinomas without opening the skull. So this was the first article in the literature where a cranial tumor was removed without opening the skull. Similarly, we have now C2 neurinoma. There is no need to do any spinal opening, no bone work, and you can work within the dura and remove the tumor in very quick time. And we can remove even these trigeminal schwannomas without doing any bone work. But of course, now my strategy has changed, and I don't want to really discuss about trigeminal schwannoma. But we first described without bone removal of this tumor, without bone work, removal of trigeminal schwannoma. So this is trigeminal schwannoma. If you know that the entire thing is within the dura, that is one. And C2 ganglion is located outside the spinal canal. This is the only ganglion located outside the spinal canal. And C2 neurinoma arises within the C2 ganglion, like trigeminal schwannoma arises from the ganglion, and then it goes up and down. Similarly, C2 ganglion arises from the ganglion. This is very important, and working within the dura, you can do a very beautiful dissection. Bilateral C2 ganglion is equal to bilateral trigeminal schwannoma is a big possibility. Like extracranial extension of trigeminal schwannoma, similarly extraspinal extension of C2 neurinoma. You can work within the dura and you can remove these tumors. And I can tell you that many of these tumors I remove in 15 or 20 minutes without any major issue. So this tumor, even if it goes extraspinal too much, you can work within the dura and avoid the vertebral artery without directly getting the exposure of the vertebral artery. I just want to quickly show you this video. This tumor I removed in exactly 7 minutes. And I don't want to show you even 7-minute dissection, but you see, cutting the dura, this was going quite intraspinal. You see, this tumor, cutting the dura, that is the first step. Then dissecting within the dural layers. You see, dissecting within the dural layers. There is no bone work. Then holding the tumor within the dura and then dissecting like a non-microscopic dissection. This is, of course, under the microscope, but by working within the dura, you can remove the part inside the spinal canal, outside the spinal canal, give slightest traction to the tumor, and you can do a very beautiful dissection in extremely quick time. And many of these tumors I have shown in various workshops in my department have been removed like a magic within 7 minutes or 10 minutes. Of course, that time is not a consideration. Philosophy is a consideration, and you can actually remove these tumors in very, very quick time without much struggle. Believe me, years ago when this diagnosis of C2 neurinoma was not such easily possible with CT scan and with various other investigations at that time, this understanding, and you start preparing all your exposures and all those things, you will unnecessarily waste your time. So I will now not like to go further too much. The other thing, another tumor in the foramen magnum is lower cranial nerve neurinoma. You see this lower cranial nerve neurinoma? It is a most dangerous tumor because if you damage the lower cranial nerve neurinoma, lower cranial nerves, you can damage the life of the person. Not many people understand lower cranial nerve neurinomas. You, of course, have to have a very elaborate exposure. But if you know that these tumors, this is preoperative and postoperatively, if you know that these tumors are also interdural, lower cranial nerves are interdural and working within the dura, intracranial component, jugular fossa component, and extracranial component are all interdural in location. You can do a very quick job and you can do a beautiful resection if you know that all three components are within the dura, work within the dura, and you can do a quick and rapid dissection and avoiding all the nerves and arteries, vertebral artery and cranial nerves, and preserve, not only preserve, you can improve the cranial nerve function postoperatively by working in the dura. So we describe first improvement of the trigeminal function after trigeminal neuronoma. We described the possibility of improvement of facial nerve function after working intradural in facial nerve neuronoma. We also describe preservation of third nerve function by working within the dura in third nerve schwannomas. Similarly, we describe working within the dura and saving the lower cranial nerve function. So this is lower cranial nerve schwannoma. Work within, see, this is the dura. Unfortunately, I am not able to show you the video here, but this is the dura. Work within the dura and you can remove the tumor in all the three components of the lower cranial nerve schwannomas. Now there is another important tumor in the foramen magnum, and that is endodermal cyst. I had reported 7 cases long time ago. This was in the year 2005. I reported 7 cases. This was the largest series at that time. Now I have 33, 34 cases, which is the largest series now of endodermal cyst. And these are, very unique, hyper intense on T2 and hypo intense on T2 weighted images like abscess. I did very characteristic imaging features, hyper intense on T1, hypo intense on T2. And then if you realize that these are not very dangerous tumors like meningioma in front of the brainstem, and don't start doing all this extreme lateral and all those vertebral artery mobilization. This is like a consistency of pus. These are liquid tumors and you can remove the liquid with a very little exposure. Although it is located in front of the brainstem, and in front directly from one vertebral artery to another vertebral artery, you don't need any exposure for these tumors. This is just open the cyst wall and the whole cyst will be liquid and it will come out in your exposure, and you do this operation in a very quick time and then remove the wall of the tumor as much as possible. You don't have to even remove all the wall of these tumors. These are completely benign tumors located in a very dangerous looking area, having very close proximity to the vertebral artery and the basilar artery, having soft calcification within the tumor. You don't need any exposure for this tumor. And understanding that these are bad location, but very good tumors like an epidermoid cyst, like endodermal cyst, and you remove this tumor in a small exposure. So we have several cases now, as I have mentioned, and beautiful long-term outcome. This is preoperative, postoperative. This is without any exposure. The bottom line is, my message is, try to understand the tumor, try to know the tumor on the basis of radiological information, on the basis of clinical information. Don't start mobilizing the vertebral artery and extreme lateral and condylar resection before you reach the tumor, because you don't have to do all those things to remove this tumor. Another tumor which I want to, I have discussed in my earlier presentation, retroodontoid pseudotumor. This tumor, retroodontoid pseudotumor, if you see the literature, several approaches have been described: extreme lateral, far lateral, transoral, in various articles, but these are manifestation or secondary features to atlantoaxial instability. And if you do fixation, this will regress and there is no need to do these tumors. So retroodontoid mass is an evidence of craniovertebral instability. This fact has completely revolutionized the field of retroodontoid pseudotumor. So you don't need to even touch them. No exposure, no vertebral artery, nothing. You have to not even reach that area. You have to do craniovertebral junction stabilization. So retroodontoids Pannus also was a very strong exposure was required for removal of pannus, transoral. And if you see the literature of 30, 40 years before 1990s, transoral surgery was very fantastic for these pannus, but they require atlantoaxial distraction stabilization, and the pannus will disappear. Even in the immediate postoperative period, the pannus will disappear by just stabilization. Retroodontoid cyst are also, you don't have to do any extreme lateral or anything. These are manifestations of atlantoaxial instability. You stabilize and these will disappear. You see, these have disappeared without even touching. This is another retrodontoid cyst. You don't have to touch this. These are unstable spine. You need stabilization. So in my article, I, I have discussed that these things do not need to be touched. No lateral, no extreme lateral, no anterolateral, no anterior. They need a different surgery. They need stabilization. Another, I'm presenting this approach because Ugur Ture is his very favorite operation is supracerebellar approach. So I'm presenting supracerebellar approach for foramen magnum tumors. So just to introduce this, I had presented a big series in the year 2006 on in tentorial meningiomas, which I like to label as tentorial meningioma. I don't like to call them CP angle meningioma or this meningioma or that epidermoid. I like to call them tentorial because they are associated with tentorium. And I presented a beautiful approach, supracerebellar approach to tentorial epidermoid tumor. And I have got huge series now, without any doubt, largest series in the world on epidermoid tumor. Supracerebellar approach for this tumor is the most beautiful approach. I also described in the year 2010, middle fossa tumor, supracerebellar approach for a middle fossa tumor. So this was the first article in the literature where a middle fossa tumor has been resected by a supracerebellar route. I know further Dr. Ture has also described various tumors, but this was the first paper in the literature on supracerebellar approach to middle fossa tumor. Then I described supracerebellar approach, which has now become very popular for petroclival meningiomas. And I had described 28 cases using supracerebellar approach. Then I have got now a very, very huge. In the year 2004, I had discussed 28 cases. Now my series is very huge on supracerebellar approach to petroclival meningiomas. But what I want to show you is supracerebellar, bilateral supracerebellar approach I use for this all right with no recurrence of foramen magnum meningioma. I want to also show, because Zia is going to talk on chordomas, I want to show an approach, supracerebellar approach to clival chordomas. So you will be a little bit surprised, but let me show you. I had discussed clival chordomas as a unique entity. It destroys the bone but displaces the soft tissue. It displaces the artery anteriorly. It is entirely extradural tumor. It displaces the cavernous sinus superiorly. So this is the unique character. I will like to know what Zia will talk on craniovertebral junction chordomas, but this is the character of chordomas. It displaces the soft tissues and it destroys the bone. So carotid artery is anteriorly, dura is posteriorly, cavernous sinus is superiorly. So on the basis of this anatomy, we had discussed in 1995 that the carotid artery is anterior, dura is behind, cavernous sinus is superior. And on the basis of this, in 1995, I described middle fossa approach to clival chordoma, and this paper is also quite widely cited, and we still do this approach. But what I want to show you is middle fossa supracerebellar approach to such chordomas. You see chordomas which go very much in the posterior fossa. You can come supracerebellar and then go to the cavernous sinus and remove this tumor. You see this postoperatively, carotid artery is displaced anteriorly, and this is in the region of foramen magnum going anteriorly, clivus, and identify the sixth nerve early in the operation, isolate and save the nerves, and then do. So this is supracerebellar. This is another approach this is a clival chordoma. You can see in the clivus. So I did supracerebellar approach to clivus chordoma and remove this tumor. This is another tumor in the region of foramen magnum and huge clival chordoma. And I did supracerebellar approach to remove this tumor. And you can see this beautiful resection. And I published this article, supracerebellar approach to clival chordomas. I hope you will find this approach interesting, if not very useful. So chordomas in the region of very common. I don't want to discuss this. I know Zia is going to talk on this tumor, but you can have a very fascinating exposure and resection on this tumor. Now, briefly to discuss on foramen magnum meningiomas. You see, I was born in the era when extreme lateral approach, mobilization of carotid artery, condylar resection were done very often. And this was the approach that I described. Midline approach. Midline approach without opening the, without manipulating the artery, without exposing the condyle, without drilling the condyle. Of course, these approaches can be done if you are using sitting position. If you are not doing sitting, you cannot do supracerebellar approach for clival chordomas. You cannot do supracerebellar approach to petroclival meningiomas. These are all, you know, if you have in your mind that sitting position is not good, then you have the neurosurgery, you will have very serious problem. You cannot do half the neurosurgery. In my estimation, you cannot do petroclival meningioma with supracerebellar approach or any, you know, epidermoid tumors was supracerebellar approach. So you, if you don't have that feeling, that sitting position, if you have that feeling, half the neurosurgery is impossible in my estimation. This kind of meningioma, anteriorly placed meningioma, go from behind, sitting position, have an exposure like this, go lateral, identify the vertebral artery, work within the cranial nerves, and you can do very quick dissection in very fast. Many of these cases I do in 30 minutes or 35 minutes. The bottom line is, if you say sitting exposure, I will not do sitting position, I will do only lateral, or I will do only this lateral or that lateral. You cannot do these tumors. You may not be able to do in any position, I will say. So these tumors are very beautifully done by very minimum exposure, midline exposure, expose the foramen magnum, work within the dura, and you can do very beautiful exposure. So you see the vertebral artery is encased, and you can do resection. Anterior foramen magnum meningiomas can be done from midline posterior, and you can do tumors which go from one vertebral artery to the another vertebral artery with a very small midline exposure of the foramen magnum over the arch of atlas, vertebral artery from this side to that side, and you can remove this tumor without doing any vertebral artery manipulation, without doing any condylar resection, and working. The bottom line is for neurosurgeon, know how to break the tumor, know how to demolish the tumor, know how to break into the tumor and debulk the tumor. Midline exposure, little bit exposure of the foramen magnum, if necessary, remove the arch of the atlas, elevate the cerebellum, work within the cranial nerves, and you can do this tumor resection. So this is my exposure, and this is the tumor, and can be removed with very minimum exposure and in very quick time. I have mentioned to you many of these tumors I remove in 30 minutes or 40 minutes, and time, of course, is not the issue. Strategy is the issue. I will now show you the most dangerous foramen magnum tumors, ossified anterior foramen magnum meningiomas. And I have a long-term follow-up of more than 10 years in each of these cases. Ossified anterior foramen magnum meningioma. You see this CT scan? This is completely bone, completely bone. And you see how the bone is ragged edges in the tumor, located right in front of the brainstem. And if you see, the vertebral artery is entering within the tumor. So this is, in my estimation, one of the most difficult foramen magnum meningioma with similar midline exposure. No extensive exposure. I removed this 10 years ago. And this tumor is completely, this patient is absolutely all right without any symptom. This is another tumor. You see this tumor going from one side of the foramen magnum to the other side of foramen magnum, completely bone, solid bone. And it is, the vertebral arteries are located in very close proximity to the tumor. And I removed this tumor several years ago, and there was some residue here and there, but there has been no recurrence and complete asymptomatic patient. This is another tumor. I will say one of the most dangerous and most impossible foramen magnum meningioma, artery within the tumor. And this tumor is completely crystal bone. So you have to drill the bone, you have to break the bone. I will suggest you read my article as to how I have removed this tumor, and 10-year follow-up. I have averaged 10-year follow-up without any recurrence and without any manipulation of the vertebral artery, without any exposure of the condyle. You can remove. Basically, what message I'm trying to give you is learn the art of breaking the tumor. Some tumors are soft, some tumors are solid, some tumors are crystal, some tumors are absolute bone, but every tumor can be broken. Every tumor should be, you learn the art of breaking the tumor, learn the art of dissecting the cranial nerves. I will quickly like to show you this video. I don't know how much, so this is the, I'm opening. If you realize, I'm directly landing into the region of the foramen magnum. This is a very thick arachnoid, and I will open the arachnoid and land in front of the brainstem into the tumor. And then I will work within the cranial nerves, cut the dentate ligament and work within the tumor. And of course, this will take not hours, not 10 hours of, maybe not 10 minutes, but not more than 30 or 40 minutes. You see, many of these tumors can be removed in very, very quick time. Only thing is, if you have the art of operating in sitting position, have the vision of operating in the sitting position. This position, this most beautiful position, is loved by Yasser Gill, is loved by Sami, is loved by Leonard Malice, is loved by very, very Cushing, Dandy. All these people were using this position. But somehow this kind of fear from this position has come in some groups of neurosurgeons. The most important thing in neurosurgery is get away from this fear of sitting position. And I will say, in my operation theater daily, at least one sitting position is going on for some tumor here and some tumor there, for acoustic tumor, for foramen magnum meningiomas, for various kinds of tumor, even for supracerebellar tumor, and these tumors can be removed in quick time. So this is the tumor, and this was removed in very quick time. As you have seen, I could not show you the whole thing because time is an issue. This is another. So I have got the world's largest series of foramen magnum meningiomas, all removed by the approach which I described, posterior midline approach. Even the tumors which are going up in the clivus, little bit exposure, retrosigmoid can be added to the exposure, and you remove this tumor. And I want to show you some other tumors. You see, this was very early in my, and I thought it was foramen magnum meningioma, and this turned out to be blastomycosis, the first and the last case in the literature. This tumor is a foramen magnum tumor, but this was a cerebellar astrocytoma. This was another osteoblastoma in the region of foramen magnum. This is a benign tumor. You remove it radically and you stabilize and you give normal life to these people. This is another tumor, which is giant cell tumor. You see how I want to show you multiple cysts and this giant cell tumor. And if you see this scan, the whole bone of the this C2 and C1 is gone. C1 is there, C2 is gone, and it is like hanging head. There is nothing. So you have to very elaborately stabilize this person if you have to give him new life, because these giant cell tumors are not benign. Another bilateral, just to show you for interest that there is no brainstem bilateral tumor. I remove this tumor from one side, then I remove the tumor from the other side, the brainstem. So many of these neurinomas are, you know, they grow over a long period of time. Whilst I was trying to plan this presentation, I got another case. I don't know what exactly is this case, but I have removed it. This is another massive neurinoma of the foramen magnum. I had reported it 20 years ago, and I have removed it completely. And this is also a benign tumor. This is a massive benign osteoblastoma of the foramen magnum. I presented it 20 years ago, and this was the post-operative imaging. This is another foramen magnum, large pseudo-meningocele, and there was bone formation around the meningocele. For the first time in the literature, I reported this. Tuberculosis of the region of craniovertebral junction is a very common entity. I don't want to go into this, and because this is basically very common in India, may not be common elsewhere in the world, but there are strategies. This case I had reported, you see foramen magnum, this is craniocervical extradural tuberculous granulation. You see firm, solid granulation. I removed those granulations completely, and I had a fantastic recovery following surgery. This was a foramen magnum lipoma, which we had reported. You don't need to remove those tumors completely. This was another hypoglossal neurinoma, is another tumor of the foramen magnum, which is interdural, can be diagnosed by this intensity of the tongue, hyperintensity on T1. Chiari malformation is very important entity of my intestine. I don't want to go into this. And I must say that recently I've described for Chiari malformation, you don't need to touch this. You need to do atlantoaxial stabilization. So foramen magnum is a beautiful entity. We have to know, we have to learn, and we have to perform. We can give new life. Thank you very much, everybody.
Thank you, Atul. Yeah, it was wonderful talk. Very unique parts. You have given your great experience on that. I will forward some questions coming from the participants. One is that, although I know that you don't drill the condyle, if you have drilled it, do you think that posture fixation is necessary in that?
Yeah, this is a very important question. I will say occipito-atlantal joint is the strongest joint in the body, strongest. And even if you completely remove one side of condyle and one side occipito-atlantal joint, the other side joint is so strong that you may not need to do any fixation. But of course, if you have removed completely the condyle and completely the atlas facet, then you do fixation, because the person might develop torticollis. He may not develop instability, but long-standing, he may develop a deformity. But there is no need. 1/3, people say if you remove 1/3 of condyle, you have to stabilize. If you remove 2/3 of the condyle, you have to stabilize. I will say the joint is so strong that you don't need to stabilize. But if you have removed the condyle completely, it is better to stabilize, because in the long run, after 20 years, after 15 years, you may get a deformity. That is my answer.
Another question is, do you change your policies, surgical policy, according to the vertebral artery variations?
You see, for the craniovertebral stabilization, for C1, C2 fixation, as you know, Mehmet, I will do mobilization. I will but my strategy will remain same. If I have to do C1, C2 fixation, no matter how the vertebral artery is, if the vertebral artery comes in between, I will mobilize it. If I will dissect it and move it here and there. But my policy does not change. In tumors, like I have shown that vertebral arteries encased, vertebral arteries encased in bony tumors, in solid tumors, in soft tumors, the policy does not change. Only thing is demolish the tumor, know how to break into the tumor, know how to
Do
reduce
you
the.
plan sometimes to clip one artery and to make it feasible to learn the which artery is dominant or which artery is not?
I will always investigate all cases very elaborately to know which artery is dominant or which artery is not dominant. And whether it is dominant or not dominant, the strategy does not change. Basically, we have to save the artery and we have to reconstruct the artery if we have damaged.
Good. Any questions from other speakers? I will ask Ugur, Ture, and Zia.
If I may,
Do you want to ask anything to Atul?
Yeah, go ahead. Yes, Zia, go ahead.
First of all, I think these are incredible cases, and thank you very much for sharing them. I mean, I think that people take it lightly. Your experience in this area in approaching these tumors. Secondly, it took me a while to understand that the C2 neuronomas or schwannomas are really interdural tumors, and I think that contribution to the literature has been very, very critical. And as so in the trigeminal neurology and trigeminal nerve tumors and so forth, the others as well. I do agree with you that I think that the majority of these tumors can be approached with a posterior midline approach, as long as you respect the tumor capsule and you debulk the tumor effectively. And it's amazing how much of that tumor can be removed. Sometimes it may require bilateral approaches, but most of the time, many of these tumors that look formidable on imaging studies, if you enter the tumor capsule and debulk the tumor, it is possible to remove them without going into any type of elaborate approach. And thank you for sharing those cases. They were very educational. And I think for the participants in the course today, it's important to recognize that Atul is really talking from years and years of experience in dealing with these tumors. And so when you try it at home yourself, the results may not look, the operation may not look as easy, and the results may not be as good as he is describing. Just a word of caution related to that.
Thank you, Zia. Do you want to comment on that?
Yeah, anyway, I will have my talk, so I can discuss a little, but I can use my time here. First of all, about the semi-sitting position, I am totally agree with Atul. And we have to revitalize the semi-sitting position. In some cases, it is a unique advantage for neurosurgeons, and we have to use semi-sitting position when it's really necessary, but not exaggerate to use for everything, in my opinion. But I like semi-sitting position also for many cases. About middle fossa epidermoid cases, I saw some pictures, but in that pictures, I prefer personally to go transsylvian. So I didn't understand what was the point. He used the supracerebellar in that case, but maybe I didn't see every picture. So I saw some pictures. And then about the chordoma, the chordoma, most of the chordomas extend the posterior fossa, but the dura is intact in most of the cases. So if dura is intact, I do not like to go through the dura. I prefer to go the base of the tumor, because tumor is bone tumor, not dura tumor, not brain tumor. It is tumor of the bone. So I prefer to go through bone, because without taking out the bone, which is the most critical issue in chordoma. To take it out the soft part doesn't help the patient. The tumor will come back, sure. So my philosophy, which I learned from Professor El Mefti about the chordoma, we have to take out the bone. And then another issue about the foramen magnum meningiomas, I totally agree. In most of the cases, posterolateral approach for foramen magnum meningiomas is more suitable, in my opinion. But there are really some cases that you show that the tumor is in between vertebral arteries. In my opinion, it is a little dangerous to go through posterior. So in such a cases, I go lateral, but I don't drill the condyle. I agree with him that we don't need to drill the condyle, but we can go lateral, because I have cases that the tumor was attached to the anterior spinal artery. So if we go from posterior, in my opinion, in my experience, it's a little dangerous to remove from posterior. Another thing that I like to ask him, I know that he has great number of C2 schwannoma. So for this reason, I am not going to show my C2 schwannomas, but I have C1 schwannoma and C3 schwannoma. Do you have, how many cases you have about
Okay.
C1 and C3?
Okay, now let me answer some questions, okay? Question number one about chordomas. Chordoma is an extradural tumor. There is no question. Extradural, you should always do extradural approach. There is no question about it. And I showed you that I have been doing for last 30 years lateral middle fossa approach. And, you know, I have shown that these tumors, Ugur, you will be happy to know that these tumors are extradural. This fact was first discussed in my article in 1994, 26 years ago. I had discussed that these tumors displace the carotid artery anteriorly first time in the literature and cavernous sinus superiorly. So lateral approaches I have been doing myself. There is no question. I showed you some special cases, you know, the tumor which are going very much posterior. If you come from the nose or if you come lateral, it may be, you know, you may not be able to reach behind in the occipital squamous. It's so posterior. And also when you come supracerebellar, the chances of saving the sixth nerve are the best because you can identify the sixth nerve, intracranial, intradural, and then isolate it. It goes along the dome of the tumor. So you can actually separate the sixth nerve early in the operation, and then you can go anteriorly into the tumor. And you remove the bone even from, you see, people are removing from the endoscope. And I will say endoscopic exposure is good. I agree. I agree only one tumor, chordoma, for endoscope removal. If somebody says I remove tuberculum celli from endoscope, I remove olfactory group from meningioma from endoscope, I will say what nonsense you are doing. But I will say good, you are doing extradural approach for extradural, for you know, endoscope, I agree. So that is one. Second, your question about epidermoid tumor, middle fossa epidermoid, why I went supracerebellar. You see, you should see all the images to know why I did, because, you know, of course, you will like to do transsylvian or subtemporal or to do totally middle fossa. There must be some special features which led me to go from the middle fossa, from the posterior fossa. As you know, supracerebellar approach is a very favorite approach of mine and also yours. That is why I showed all these things in my presentation. And you can have very beautiful exposure to the medial temporal structure and medial temporal epidermoid, which are going little bit in the region of the tentorium from below. You should see more pictures in that case. The other question that you asked, sitting position. Of course, sitting position is a beautiful position and we should use it very selectively and not for every case, but in many cases it can be game changer. For vitro like so beautiful temporal lobe vitrectomy, this vitrectomy, and whole doing all those things. Use that. I'm not saying sitting position, but it is a fantastic approach and we must learn. As far as C1 neurinoma and C3 neurinoma, these are very rare tumors. C2 ganglion is the biggest ganglion in the body, in the spine. Gasserian ganglion is the biggest ganglion in the whole body. Neurinomas arise from the C2 ganglion and from Gasserian ganglion, very rarely from C1 and from C3. So I would like to see your cases, of course. Thank you very much.
Thank you very much.
Thank you, Atul. And thank you, all the discussers for very nice section. Now,